Hi guys. So the lecture for this week is kind of a hodgepodge of monitored anesthesia care and a little bit of general anesthesia, some thermoregulation, and some other topics. So I broke it down into I think 7 videos, and this way you can go in order, you can go out of order, and do whatever you like. So you kind of makes your studying a little bit easier. So you can see the objectives are extensive, and I tried my best to try to include a little bit of everything and put in all the important pertinent topics in the lecture. And again, the breakdown, we start with some terminology. Next video is going to be providing MAC, followed by pharmacologic principles, drugs, respiratory effect of the sedatives, then some awareness on thermoregulation. Now, I think a good place to start is by going to ASA physical status classification. And quite often I see that particularly ASA 3 is overused. So let's go over all of them. So ASA 1 is really the totally healthy patient who doesn't smoke, who's not obese, who doesn't take any medication. And we don't really see this very often anymore. Most common type of patients that we have are people with mild to moderate systemic disease that is well controlled, and there's no organ dysfunction, there's no functional limitation. And a good example would be a 40-year-old guy who smokes, or a 40-year-old guy who's obese, a 40-year-old guy who takes cholesterol medicine or blood pressure medicine but doesn't have any other problems, goes to work, exercises, just all the usual things. Now, ASA3 patients are the ones with severe systemic disease of at least one organ, and they do have some functional limitation. So, an example of this, the common one, is stable angina. Everything is controlled, everything is well controlled, but there is functional limitation from angina. Like moderate kidney disease would go in here. I would argue that severe obesity should go in here. People with COPD that are, limited in function, that should go in here. Now, ASA class 4 are severe systemic disease that have some end stage organ problems. And these are the people that their life is in jeopardy with or without surgery, like people with heart failure, people with severe renal failure, people with cirrhosis. Now, ASA 5 this is a little bit different. So ASA 1 to 4, the condition that the patient has for surgery doesn't come into play. Like somebody has a renal cancer, but otherwise healthy. That patient can be considered ASA 1. But when it comes to ASA 5, that's a patient that needs an operation immediately or the patient will die. This is like a ruptured AAA. So these patients, we often misclassify them into ASA 4 or 3E or 4A, and they should be ASA 5. And ASA 6 are the patients for organ donor. These are brain dead patient, and emergency or E for whenever there's an emergency case. So, what are the goals of monitored anesthesia care? What are the goals of MAC? Really, the goals are the same. You want to, same as general anesthesia, you want to be able to give patients sedation, amnesia, anxiolysis, analgesia, and I didn't write it by akathisia, so the patient is not running away from surgeon when they're trying to cut. Compared to GA, MAC results in less physiologic disturbances, so hemodynamics are more stable. The recovery is usually faster and quicker discharge from the hospital, and generally speaking, if done properly, it can lead to better patient satisfaction. And again, this is when MAC is done properly and adequate discussion with the patient about remembering things or not remembering things. When the expectations are met, patients are generally happier. Now, sedation continuum. This is near and dear to my heart, and whenever I think about it, I think about Paco. I miss him. So what is minimal sedation? Minimal sedation really anxiolyzes. Just keep the patient relaxed. Patient respond normally to verbal command. And the respiratory and cardiovascular system, there's no effect on them. There is no problem with airway patency and reflexes. And the common drug used are oral benzodiazepine. And CMS does not define minimal sedation as anesthesia. So don't write sedation in the consent form because that is not a service you're allowed to provide. Nurses are allowed to do it under direction of physicians. Anesthesiologists are not allowed to do sedation. We're not able to bill for it. And I will get more to it in just a little bit. So what are an example of minimal sedation? This is a guy who gets anxious, a little claustrophobic for MRI, so the PCP writes for, some Ativan to take in the morning. That's minimal sedation. So patient talks, walks, able to do whatever he wants, and is just a little bit anxio. We've done a little anxiolysis. Now, moderate sedation. This used to be called conscious sedation commonly, and slightly deeper depression of consciousness. But patients should still respond purposefully to verbal command with or without light tactile stimulation. And the respiratory and cardiovascular system are not affected. No problem with patency of airway and airway reflexes. And commonly we use IV benzodiazepine and opioids. Again, CMS does not define moderate sedation as anesthesia. You cannot bill for it. So don't say I'm going to do conscious sedation on the patient. So what are some examples of this? These can be something like, somebody has a colonoscopy and the GI attending is directing GI nurse to give a little bit of Medaz, a little bit of fentanyl, and titrate to effect. Now, deep sedation, what is that? So here we have significant central nervous system depression. Patients are unconscious and are not easily aroused, but they should respond purposefully to painful stimulation. What does that mean? That means if I cut the skin, the patient's going to withdraw. There is respiratory depression and patients are not breathing very well on their own. There may be cardiovascular depression and decreased airway patency. And these are the patients that need some chin lift, jaw thrust, and even oral or nasal airways. And typical drugs are benzos, opioids, propofol, ketamine, etomidate, dexmedetomidine. And an example of this would be a guy with a broken bone goes to the ED. The ED doc gives some benzos or some ketamine to reduce the fracture. Can we bill for it? No, we cannot. CMS does not consider this a service that the anesthesiologists provide. What is general anesthesia? Again, goals are the same, but here we have complete loss of consciousness and lack of arousability to painful stimulation. So when you're doing a hernia repair under sedation, patient cuts the skin, there is no response. That is no longer sedation. That is general anesthesia. Significant cardiovascular, respiratory depression, no airway patency, so you need a mask, LMA, ETT, and hypoventilation and drug-induced depression of neuromuscular function. So again, you need positive pressure ventilation. Now, can't talk about anesthesia without the historical Goodell's stages of anesthesia. Now, keep in mind, this was developed with ether, which is a much more soluble inhalation anesthetic, so all the stages were prolonged. Now, some argue that we no longer have this with sevoflurane or desflurane or even isoflurane because they're much faster in terms of their action. But they do make a good point. So what is stage 1? Stage 1 is analgesia and disorientation. So this is from induction to loss of consciousness. And here you have the pupillary reflex. Pupils are not pinpoint. And you still have a lid reflex. Then you go to stage 2. Stage 2, the excitement or delirium stage that you all have seen, it's from loss of consciousness to the onset of automatic breathing. Here there is no eyelash reflex, but other reflexes are still there and are in fact enhanced, so coughing, vomiting, or struggling. There is irregular respiration with commonly you see breath holding here. So this is the time that if you intubate the patient, the risk of your respiratory reflexes kicking in and going into bronchospasm, laryngospasm, all that stuff, that goes up. Stage 3 is called surgical anesthesia. And this is from the onset of automatic respiration to respiratory paralysis. And it's divided into multiple phases. And again, we're not talking necessarily about giving paralytic. This is paralysis from the inhalation anesthetic. Plane 1 of stage 4 is from the onset of the automatic respiration to cessation of eyeball movement. Eyelid reflexes are lost. Swallowing reflex is gone. Their marked eyeball movement can occur, but conjunctival reflexes are lost. And then we move on to plane 2. This is from cessation of eyeball movement to beginning of paralysis of intercostal muscles. Laryngeal reflexes are lost, but inflammation of the upper respiratory tract increases reflexes and irritability. Corneal reflex disappears in this plane. Secretion of tear is increased in this plane. And this is commonly a sign of light anesthesia. And respiration is automatic and regular. Movement and deep breathing as response to skin stimulation disappears. In plane 3 starts from the beginning to completion of intercostal muscle paralysis. Diaphragmatic respiration persists, but there is progressive intercostal paralysis. Pupils are dilated, and light reflex is gone. The laryngeal reflexes are lost in plane 2, can still be initiated by painful stimuli arising from things like dilation of the rectum or anus or cervix. And this is the desired place for surgery when there is no muscle relaxants used. Plane 4 is from the complete intercostal muscle paralysis to diaphragmatic paralysis. Now, a stage that most people don't think about is stage 4. What is stage 4? It's from stoppage of respiration until the patient's dead. And this is not really an anesthetic stage, but it's an anesthetic overdose. And it causes medullary paralysis with respiratory arrest and vasomotor collapse. Pupils are dilated and muscles are relaxed. Patient is dying or dead. Now, what is the ASA definition of MAC? MAC doesn't refer to any particular level of sedation. It's defined as a specific type of anesthesia service requested by the anesthesiologist for the care of a patient undergoing a procedure. MAC requires flexibility to match sedation level to patient's need and the procedural requirements. So the more painful the surgery is, the more pain medicine you give. If it's not painful, you don't give it. And according to ASA, there are two significant differences between MAC and moderate sedation or analgesia. MAC implies sedation and analgesia that is deep sedation, but it only implies it, doesn't necessitate it. MAC should involve some degree of verbal communication with the patient. MAC providers must assure return to full consciousness, pain relief, and management of adverse effects from medications that we gave during the procedure. So you need post-op care that's identical to general anesthesia post-op care. MAC services must include a request by procedure physician, consent and acceptance by patient, performance of a pre-anesthetic evaluation, administration of anesthetic care, and any pharmacological therapy as deemed necessary by your judgment, personal participation in or medical direction of entire care team plan, continuous physical presence of an attending, resident, or a nurse anesthetist, continuous availability of the attending for diagnosis and treatment of emergencies, adherence to all institutional regulation, usual non-invasive cardiopulmonary monitoring, oxygen administration when indicated. So again, this is no different from general anesthesia. MAC, Monitored Anesthesia Care Service, has the same requirement for pre, intra, and post-op care than general anesthesia. Keep in mind, I'm saying MAC, I'm not saying sedation. Now, what are the Medicare and Medicaid definition of MAC? According to CMS, MAC includes all the necessary components of the general anesthesia. This requirement contrasts significantly with minimal or moderate sedation analgesia. Doesn't have any of these requirements. When giving MAC, we will provide a number of specific services like diagnostic and treatment of clinical problems that occur, support of vital function, giving sedation, analgesic, hypnotics, etc. for patient safety, psychological support and physical comfort, don't forget this part, and provision of other medical services as needed to complete the procedure safely. MAC cases receive the same level of payment as general or regional anesthesia, so same RVUs. And if you do a 1-hour surgery under general anesthesia, the payment is the same as when you do 1-hour surgery under MAC anesthesia.